Good afternoon. I'm going to go ahead and call the Health Subcommittee of Appropriations meeting to order, and we'll begin. I'll ask you to bear with us a little bit. We're doing this live and virtual, so I have my technology expert seated up here with me, and with the folks from House Technology, we'll get through this. What we're going to do is we're going to hear from our departments, and then we have some that will be giving public comment virtually, and we also have some who will be in person to make some public comments as we go along. So if the first on our agenda is the Department of Community Health, that would be Commissioner Frank Berry. Are we on?
Okay.
Good afternoon, Mr. Chairman. Can you hear us okay?
Yes, sir. Go ahead.
Very good. Thank you, Mr. Chairman, and good to see you. I certainly wish that it were in person, but understand the precautions that we're all taking, and thank you for your willingness to accommodate the Department of Community Health. I wanted to give a couple of brief updates before Lisa gives an overview of the budget and certainly can answer questions. The first one that I know many people have questions about are the 1115 waiver. And with me today, I have Lisa, along with Blake, Mariel, our Chief of Staff, Blake Fullenweider, our Chief Health Policy Officer, Kelly Richards from Budget and Finance, and of course, Lisa Walker, our Chief Financial Officer. So we'll be able to dive into questions as needed. But on the 1115, Friday night, I received a letter from CMS saying that they are reviewing our application. We are reviewing that letter now, along with our partners over at the governor's office and our other partners with Deloitte, who have been helping us with the waivers. Really, there's not a tremendous amount of information to share at this point, other than we are strategizing on what our next steps will be. We believe that our waivers are written in a very, very sound manner. We had been granted approval from the previous administration's CMS, and we'll continue to push as hard as we possibly can to ensure that we're moving in the right direction as it relates to our waivers. If we have further questions that we want to dive into the details on, of course, the architect and author, Blake, is here, and we can get into some of that. The second one, and Mr. Chairman, and I know we have put you in a little bit of a tight spot along with members of the General Assembly, and I want to apologize. One of the things that we've learned through the last 11 months with COVID is breakdowns in communication can be very problematic. And I want to apologize to our hospital system for me not doing a better job of communicating. Lisa has kept me up to date on the UPL 2020 UPL calculations and the private tier 2 programs. And I have not done an adequate enough job of conveying where we are with CMS. Just recently, we did get approval for the tier 2 programs. And I know Lisa has communicated that as recently as yesterday to several of those key stakeholders. But again, I want to apologize. Where we are with CMS right now is that they have conveyed to us that they have all of our calculations. They have asked us to be patient. They recognize that they are behind. They were behind even before the change of administration, and that has not been caught up yet. So we're in a holding pattern. I know that is not the answer that everybody is wanting to hear, but again, I apologize for not doing a better job of communicating that, even that information ahead of time. They have had our information for quite some time. We are frustrated as well, but certainly need to understand the challenging situation that they're in. We have several new people. We've had, from what has been conveyed to the department, there have been many retirements as well. We will continue to push on this issue. I want to reiterate, there are no outstanding issues that they're waiting for us to get back to them on. And so, but we will continue to push as hard as we can to get an answer on that and to be able to move forward. We understand how urgent this is for our hospital system. They have always been fantastic partners, and we need to I need to demonstrate the same to them. And please, for you and the members and to the hospitals, most importantly, I will do a better job of communicating that. The last one that I wanted to touch on, again, I know that there has been a tremendous amount of discussion about CLS. Certainly working in partnership with our sister agency at the Department of Behavioral Health and Developmental Disabilities. We have had extensive conversation with them. We have heard from community members and stakeholders. These are very difficult discussions, but I want to also recognize that there are 7,000 people on a long-term planning list, 13,000 people on waivers, and between our department and the Department of Behavioral Health and Developmental Disabilities, our goal is to serve as many people as possible. We recognize that there are very, very complex and both behaviorally challenging situations along with medically complex situations that may present themselves. And I believe that between the two departments, we'll be able to work with family members and stakeholders to ensure that we provide high quality care through our network of providers. And I know that, again, you all have had to field a tremendous number of questions. I know that there's been a lot of dialogue about this, and we are prepared to continue that dialogue and continue to meet with family members, with the Department of Behavioral Health and Developmental Disabilities, and just you have our commitment that we, along with the Department of Behavioral Health, understand the complex issues that we are dealing with, and know that these are difficult discussions. So, Mr. Chairman, I certainly want to be respectful of time, and we can get into the numbers, but I also want to be totally available for questions that may come up, and can defer to you if you'd like to hear from our budget now and then open it up for questions after, but I'll defer to you and your leadership.
Let's do that. Let's go ahead and make the presentation, and then when you finish with the presentation, I'm sure there'll be some questions, and we'll open it up to the members for questions with you, if that's okay.
Yes, sir. Thank you. Lisa, I'll turn it over to you for the budget presentation. Thank you.
Good afternoon, Mr. Chairman and members of the committee. I will be going through our presentation by referencing the tracking numbers as it relate to each item, and go through each item and state what those amounts are as it relate to our agency's recommendations. The first three items, starting with our Departmental Administration and Support Program, is 17.1.2. And that's to provide funds for a prior authorization of independent lab services. And that was a change so that beneficiaries that were getting lab work would have a prior authorization before proceeding, because we had seen some increasing in costs. And this will help mitigate whether those costs are really attributable to laboratory services and to help output some fraudulent-like activity. The next item is 17.1.3, provide funds to begin the implementation of the Patients First Act. And this is funding that would be needed in terms of administrative-wise, some staffing, some contractual services related to supporting our system that would go into the Patients First Act, and that's $2,625,513. The next item is 17.1.4, reduce one-time funds for planning and implementation of the all-payer claims database. And this is a reduction of funds within our base budget. And we also presented in our amended year budget where this was an increase for ongoing support for the all-payer claims database in the amended year, but this is a reduction in our base year. The next item is for the Healthcare Facilities Regulation Division, and this is why nurse surveyors go out and survey nursing homes. That item is 17.5.1, nursing home program stabilization, in the amount of $4,860,000, and that amount will go to our contractual services. There are national contract vendors that CMS recommend that each state use to help procure services to reduce the backlog for our surveys in the program. The next item is Indigent Care Trust Fund Program, And that item is 17.6.1. Increase funds to annualize the state match for disproportionate share hospitals payment for private deemed and non-deemed hospitals. Most hear us refer to that as DISH. And that amount is 35 million. Usually you see this in the amended year on an ongoing basis every year in the amended. This is being placed in our base budget so that moving forward, any changes can be incremental changes as it relates to DISH payments. Next slide. The next slide address our benefits program, which are the Age Blind and Disabled program, Low Income Medicaid program, and Peach Care for Kids program. Some of the items have been combined related to our growth and FMAP. And the first item is 17.7.5, 17.8.1, and 17.9.1. That's a combination of the ask for our growth in our benefits program of $64,162,462 as it relates to growth. We looked at our projections in terms of seeing things somewhat return to normal in terms of utilization might be ticking up and our enrollment also. And that's the amount attributable to that growth. The next item is a restoration of our FMAP and enhanced FMAP. And those items are in 17.1.3, 17.7.4, 17.8.2, 17.8.3, 17.8.4, 17.9.2, and 17.9.3. And that's the restoration of our FMAP that you've seen in the previous budget presentations that has been reduced. And this is just a restoration of that FMAP adjustment for enhanced and for regular FMAP. The next item is 17.7.1, increase funds for the hold harmless provision in Medicare Part B premiums. And this is our ask of $6,309,642 for that Part B premium. And the Part B premium is for dual eligibles. And that Part B actually goes for the assistance in terms of paying for their premiums, their deductibles and copays. The next is 17.7.2. Increase funds for the amount for the Medicare Part D clawback payment, and that is also for dual eligibles, and that's the assistance dual eligibles receive in terms of prescription, and that amount is $6,463,107 in terms of the Part D clawback. The next item is 17.8.5, restore one-time reduction in funds for the risk corridor. Last year, when we implemented risk corridor as a result of our budget reduction, it was to offset risk mitigation and do a retro rate adjustment. And this is a restoration of part of that for FY22 of $51,097,342. I do want to reference that the total reduction was $102 million when we submitted it, and this is half of the restoration. And we are continuing to monitor what utilization will impact as it relates to those adjustments in the program. The next item is 17.8.6, provide funds to begin the implementation of Patients First Act. And the amount you see as it relates to Patients First here is that what is being projected in terms of the benefits portion, as opposed to what you saw and heard me mention earlier in terms of the support in terms of staff. And that amount, and this amount is $65,460,836 to support the benefit portion of the enrollees. The next amount is 17.8.7, reduce funds to reflect a repeal of the health insurer fee, which is the HIF fee, and that amount is $38,545,835 in terms of a reduction, because that will be going away where states will not have to pay that HIF fee in terms of provider coverage. The next slide, Well, that concludes our budget presentation, Mr. Chairman. As it relates to our budget, usually we give an overview of the financial status of the state health benefit plan, and that's what we will be covering next. The slide that you see in terms of our financial status as it relates to the state health benefit plan is what we finished the past fiscal year in terms of fiscal year 2020. And you will see projected out years in 21, 22, and 23. In fiscal year 2021, we finished the year with a net surplus of $228,265,582 in terms of the plan. And that is in a better position, I want to say, than we had presented to you in the previous year. Utilization, even in state health benefit, had gone down, which actually generated surplus as it relates to the expenses compared against revenue. As you can see in the out years in 2021, 22, 23, we see an escalation of a deficit over those 3 years. And the projection for the program is projecting baseline expenditures to increase as we move into 21, 22, and 23 as it relates to that expense compared to revenue. And in the current fiscal year, 2021, if we end in a deficit, we would have to utilize state health benefit reserves to help cover that cost as it relates to that deficit, unless program changes occur in terms of additional revenue coming into the program. And I'll pause for any questions based on our budget presentation and the financial status as it relates to state health benefit plan.
Great. Thank you, Lisa. I think we may have a couple of questions. Any members of the committee, and then we also have some who are with us virtually. Number 6, is that Representative Hughley?
Thank you, Mr. Chairman. My first question is for the commissioner, as he talked about the plan review that has been sent back from the federal government. According to the newspapers, they're talking about adding in more incentives for states that have not yet fully expanded Medicaid. Would you all be reviewing these incentives if they come to fruition and redoing your plan, or how would that work?
Yes, ma'am. Thank you for the question. We're reviewing all options, and it's too early to determine what direction the state will go. The discussions really, the letter just came in after hours Friday night, and we're in the early discussions of, so what does this mean? We will be reaching out to CMS over the next couple of weeks. We have 30 days to do a response and hope to have a more comprehensive question and answer with them on those next steps. But right now, we're looking at all options.
So is it safe to assume that at the end of the day, you're trying to balance cost and the number of people and the services that can be covered? Is that the?
Yeah, I think that's a great way to frame it. We're always looking at how much will something cost, how many lives can we get covered, the federal FMAP percentage that gets incorporated into all of those. So that is absolutely a part of the discussion.
Mr. Chair, I also have a couple of questions on the budget, if it's okay. On 17.1.2, when we talk about the prior authorizations of independent laboratory services, will this have any impact on the access to patient services because of the prior authorizations?
No, it should not impact access. If a beneficiary needs lab services and that doctor actually give authorization for that beneficiary, recommend that that beneficiary receive lab services, it will go through a prior authorization, and once it's authorized, that person will get the needed lab that they need.
One other question, and that's on 17.5.1. Who has this contract for the nursing home surveys and how often are these surveys being done?
Uh, Our surveys are usually done on an ongoing basis, and the contractual services that we have two contracted vendors, and those are CMS recommended contractors. One is called Accelin, and the other one is HMS. And these are vendors that CMS recommend all states to use.
Thank you, Mr. Chairman.
Mhm.
Do we have
Thank you.
other questions from the committee? Anything virtually? Okay. Mr. Commissioner, I have a question for you. We've touched on this and explained it pretty well, but on the waivers, and I realize this information that you just got back from the feds came in late this weekend. Was there any mention of any other provisions in the waivers, or is just the work provision is the only thing that was discussed in that?
I'll double check with Blake. Blake, would you mind? Blake has read over the letter many, many, many times. So if it's okay, Blake.
Yes, sir.
Certainly. Thank you for the question, Mr. Chairman. They specifically make reference to what are called community engagement requirements. We actually call them qualifying hours and activities requirements because our waiver is designed a bit differently than the other states. We're not the only state that received a letter in this regard. They do make reference in the letter as well that the Georgia Pathways to Cover demonstration includes other authorities that CMS approved in the demonstration when it was approved in October of last year. And they note that CMS will also review those other authorities and will follow up once their review is complete. So at this time, they're only looking at our qualifying hours and activities provision, but there could be additional items that they seek to bring to the state's attention.
Blake, do you have any idea when you may hear more about that? Is if they're going to disqualify some other parts of that, or what? Do you know what kind of timetable you might be on?
We're not 100% sure at this point. Again, we're under initial review of the letter as we speak. I will note that we have 30 days to provide written response, so I think that in fairly short order, we'll have greater clarity. Whether or not we will hear prior to the state issuing our formal response to the CMS request, I don't know that yet. But we are hopeful that as this process moves forward, we can move forward expeditiously, understanding that the waiver is slated to go into effect on July 1st of this year. So time is drawing near.
Okay, thank you. Any other comments or questions from the committee or any of those that are attending virtually? Nothing. Okay, thank you very much. Mr. Commissioner and Lisa and Blake, thank you for your presentation. I'm sure that we'll be discussing this as we move through the process, and thank you for being with us virtually today to go over your budget and explain where we are in the process. Thank you very much.
Thank you, Mr. Chairman and members of the committee. Thank you.
Okay, next we're going to hear from LaShawn Hughes, who is Executive Director of the Georgia Board of Healthcare Workforce, and this will be online as well. Director Hughes, are you there?
Tell her to unmute herself.
Unmute if you're muted there.
Hi. Mr. Chairman, can you hear me?
Yes, we can. Thank you.
Okay. Thank you. I'm going to share my screen. Thank you. I'm sorry, I am echoing. Can you still hear me?
I think you called in. She says, hang up and see if we can still hear you.
Well,
Or
Okay.
recall, you got to call.
she called in twice.
Did you call in twice?
Yeah, she's got to mute something.
I called in once. I thought, okay, I'll hang up and call back.
Welcome to Zoom. Enter your meeting ID.
So I think, see if she can.
Try it now. Can we hear you? They think you already might be in twice, and they were trying to
Enter your
do away with one.
participant ID, followed by pound.
She was having audio
Otherwise,
issues at the
just
start.
press pound.
Yeah.
Please enter the meeting passcode, followed by pound. You are in the meeting now. There are 8 participants in the meeting. This
Can you hear me now?
recorded. You are muted. You can mute or unmute yourself by pressing *6. You have been added to the waiting list. You cannot talk or listen until the host admits you to the meeting.
So she
You-
couldn't hear us, but.
Or unmute yourself by pressing *6. You are unmuted.
Mr. Chairman?
We can hear you now.
Okay, great.
Let's-
Thank you. I thank you for the opportunity this afternoon to talk to you about the Georgia Board of Healthcare Workforce.
Go ahead. Go ahead. We're good.
Gonna share her screen.
All right?
Okay.
So our first presentation is just to tell you more about the board. So the board consists, we're the Georgia Board of Healthcare Workforce, and I thank you for the opportunity to speak to you this afternoon about the board and also the Georgia Composite Medical Board. I'd like to thank you on behalf of the staff of both of the boards for the one-time salary supplement. The raise impacts 6 employees for workforce and 29 medical board employees. To tell you a little about the board, for those who don't know, the board addresses the healthcare workforce needs of Georgia communities. We support medical education programs. We work to increase the numbers of healthcare practitioners, not only physicians, but advanced practice registered nurses, PAs, dentists, in our underserved loan program. We also produce reports and we house a visualization program. And we're happy to say, and I'd like to thank the Board of Nursing and also the Nursing Leadership Coalition for sharing their nursing data. And we have our nursing visualization site up and running now. So we're thankful for that. Our only line item change is 17.12.1, which is our GME program. 1712.1 is the board is currently working with programs to address the shortage of forensic pathologists. When COVID came, we realized that the state realized that we needed more forensic pathologists. So there are 2 programs in Georgia, MCG at Augusta and Emory. So we're working with them to figure out how we can attract more people, possibly with loan repayments. 17.12.2 is to increase funds for 188 new resident slots in primary care. And I know that I speak for these programs that we're very grateful for the legislature for putting this funding back in. 17.12.3 is FMAP, and it's an increase from 67.30 to 66.58. So our total is $24,787,190. And the only other, all other line items are neutral. As I mentioned before, graduate medical education is the only place that we had a change. And that is the end of the workforce board, if you have questions.
Okay. Do we have any questions from members of the committee? I have one for you. Thank you for that report. The loan repayment program that was initiated several years ago, a lot of members of this committee and others were very interested in it, into establishing that. Could you talk to us a little bit about how that's working and what the demand is and the results of some of those programs that have been implemented to help with these students repay the loans if they agree to go to underserved areas and so forth?
Yes, sir. So for physicians, last year we gave 48 loan repayments, and they went to 31 different counties in Georgia. We had the dentists, we did 15 of those, 14 counties. Advanced practice registered nurses, we had 25 recipients, and they went to 16 different counties. And PAs, same thing, 25 at 16 counties. I would tell you it's a very popular program, and we don't probably do enough to advertise it, but this year alone, we gave 21 PA loans, and there were 4 that needed it, that we couldn't fund. For dentists, we gave 11, and 4 did not have the funds available as well. And for APRNs, which is a big number, one thing the nursing community does a great job is advertising and getting the word out. We gave 21, and there were 60 additional people who wanted the payment that the funding was not available. And physician assistants, it was 11 of those that did not receive an award. So it's a very popular program.
So it sounds like it'd be safe to say that if the word really got out, you'd have much more demand than you have now, and that it's been successful. And if you had more resources, you would be able to award more of these loan repayment programs.
Absolutely, yes, sir.
Great. Thank you. Anyone else have a question? Have one more for you. When we were having hearings back, it seems like forever ago, pre-COVID, I guess, and we talked about the shortage of medical examiners, pathologists who did the medical exams for the GBI and other areas, and the real shortage there, and there was a need, it seemed like to us, to increase this program so that we could turn out more of these medical examiners because there's such a high need for that. And we've talked to a couple of the schools in the state who have indicated that they want to work to try to help produce and turn out more of these examiners. Have you had any inquiry as to far as if we were to come with some loan repayment program, as you had mentioned maybe earlier, or they would agree to go to underserved areas or work in these specific specialties? Has there been any interest that you have heard from some who might be willing to participate in that program?
We have a former board member that owns TIPA Labs. He's a pathologist, and we had spoken to Dr. Dean Hess at MCG, and they thought if we had funding for those programs, they could fill that program if there was some incentive to get people to come here.
Okay, but I'm correct, am I not? At this particular time, we don't have any incentive to encourage anyone to go into that particular area.
No, sir, we do not.
Okay, thank you. Any other members of the committee or anybody online have any questions for the director? Okay, well, you must have done a good job explaining that. Thank you.
Okay. All right, I'm also here
Executive.
for the Composite Medical Board as well.
Anybody else? Thank you very much.
She's doing medical board.
Oh, okay, you're gonna do, I'm sorry, I'm looking at my notes. You're gonna do the medical
I'm
board.
still here.
Yeah, all right, great, great. Go right ahead, I'm sorry.
Okay, so now I'm here to represent the Georgia Composite Medical Board. And just briefly to tell you some things about the board, we're the licensing authority. And I just wanted to highlight that last year, year before last, was passed to license genetic counselors. So now, in a year, we've licensed 393. So we probably have gotten the bulk of them licensed already. People now are coming in from other states to be licensed here as well. So that's a new licensure category for us. And I also want to highlight that the board has been responsible for emergency practice permits. So since last March, when the executive order went into effect, we've issued 238 emergency practice permits, and these are people to help with the COVID outbreak. So we're continuing to do that every month. They're continuing to come in. So, and then the board consists of 15 members appointed by the governor. We have 2 consumer members on our board and 1 physician assistant. We have 29 staff members, and out of that, 6 agents that handle complaints that are sworn police officers. I also like to mention that the board has been given $2.3 million for revenue, and we have returned $7 million back from our renewal fees, application fees, fines, and other administrative fees. So we're doing a good job of maintaining what we're supposed to do as far as being cost effective. We do not have any line item changes. 17.17 is the board's budget, 2.3, and it remains consistent, and that is all I have, Mr. Chairman.
Okay, any other questions or comments from the committee or the medical examining board? I've got one for you. Have you had instances where maybe retired physicians who are no longer actively practicing but would like to come back and during the health emergency offer and volunteer their time to be able to help administer the vaccines and this sort of thing? Do not you have a program that allows them to do that?
Yes, sir. If you've been retired less than 5 years, then you're probably one of the ones that's issued that emergency practice permit. So we have a lot of retired physicians that came back out, PAs that have stopped, raised families, and joined the ranks of working at World Congress Center, seeing patients as well.
I have a question for you. Go hit your button there. Let me.
Are the physicians who come back out on the emergency order from retirement, do they have to, or are they still required to do CE to retain that? Or is that not required? I know now you have.
If you're
yeah.
I'm sorry.
No, go ahead.
So if you're volunteer, you have to get 10 hours of CME if you get the volunteer and health license. But the people that are coming to help with COVID, there's no requirement for continuing education.
Thank you.
Okay. Anyone else? Yes, ma'am. Representative Hughey.
Thank you, Mr. Chairman. How many permits have you issued for people coming to help us with the COVID crisis?
Our total number is 2,038.
And so all of these are for COVID?
All of these are, yes. Some of them could be, what we found out as well in this permit is a lot of college students came home who had been seeing counselors in other states. So if you don't have a license in Georgia, you can't treat anyone here. So some of the counselors, also Secretary of State has had this, and psychiatrists are treating patients here by telehealth. And so they're using the emergency practice permit for that as well.
Thank
you. Okay, any other questions or comments? Good. Thank you very much. Appreciate your being with us today.
Thank you.
Okay, next on our agenda is the Department of Public Health, Dr. Toomey.
Thank you so much, Mr. Chairman. Can you hear me all right?
Yes, we can.
Oh, but thank you. I'm here with a number of people and our finance team, and I'll go fairly expeditiously through the budget and with some additional updated information on our COVID vaccination response since we last met. And hopefully there'll be time then for questions. Just to begin, a reminder of how our state office and public health districts are configured. It's an unusual configuration compared to other state health departments, that we have public health districts with health directors reporting to me and 159 county boards of health that are independent of the state office. But I want to reassure you that we have been working diligently together in a way that I've never seen before in the history of public health in Georgia, and I've worked for many years here. I mean, because this is how we have to respond in a pandemic, as a united system of public health. Next slide. I wanted to go over the governor's budget recommendations initially. The first is the Georgia Regional Coordinating Center, $506,000. If you recall, when I believe it was last year or late last year before, Grady had a ruptured pipe that led to a significant number of their floors that were not usable, and really a crisis in terms of availability of bed space in the metro area. Our EMS team, along with Grady, set up this coordinating center to direct EMS traffic to available bed space for those who are accepting trauma or other patients. And we realized it was really such a good way to operate to ensure that the right patients were able to go to the right hospital at the right time, that this became codified with your help and with much thanks. This will just make that program whole. Although it's located at Grady, it is not a Grady program per se. It's our program in conjunction with Grady, not unlike the Poison Center that serves the state as a whole. This program serves the entire metro area as a whole. And these funds pay for positions as well as, completes the process to put this in place. But it's really serving all the hospitals in the metro area. Under infant and essential health treatment services, we have a federal medical assistance percentage, FMAP adjustment, and just that our federal share is reduced, as you've already been made aware. And so that's that needed $30,963. Under infectious disease control, there's a continuation of this is year 2 of a 3-year PrEP or pre-exposure prophylaxis program that was codified in the 2019 session. We were very happy about this opportunity to demonstrate the effectiveness of PrEP in areas where it hadn't been used before, and Towns County and several other counties in North Georgia, including Stevens and Hall, are likely to be additional rollout sites, as well as Fulton, which has a PrEP trial going on, but this will be an enhancement of it. This program will allow us to do some assessments of the effectiveness of PrEP within different populations who are at risk for HIV, whether because of their drug use or other behaviors. So this funding allows us to continue that program and continue those assessments. One of the other situations we had from last year was that some of our of our STD HIV positions were inadvertently reduced in a budget reduction that was made. And this $144,026 is just a restoration of those funds for those positions, which are needed to continue with the program. And then an additional continuation for our program is the body art licensure. This is something that you may recall. The requirement for body art artists, 1,300 or more of them throughout the state to be licensed was passed, but we didn't have the funds to be able to issue the certificates. We didn't have the personnel and staff. So this funding will allow us to hire several staff and additional administrative costs to issue the certificates to these body artists who are then practicing throughout the state. And the local health departments, as you probably are aware, actually do the inspections of their facilities. But there was no program in place to actually issue their licensing certificates. And this puts that in place and then completes that program that was passed several sessions ago. And then we have an adjustment for the teachers' retirement system, $6,341. I wanted to talk a little bit about the fiscal year 2022 ongoing funding needs based on the supplemental budget. And I want to sincerely thank you for recognizing the situation we were in public health and the importance of providing some additional support at this time. I think as I've said to you many times, the pandemic has unmasked, so to speak, our capacity to implement quickly and in an agile way many of the things that we were required to do was hampered by lack of infrastructure, as well as limited leadership staff at the state office. And what these positions do, the critical public health leadership positions do, is provide additional state-based leadership that will work in addition to the commissioner's position. This funding for FY22 provides the salary and annualizes the funding for those positions in the next year's budget. In addition, we recognize that these surveillance systems, the vaccine management system, which we had in place and literally began to fail within a few days of initiating the first vaccinations, needed to be replaced and that infrastructure strengthened. With the funding we got in the supplemental, we'll be able to do that. And we hope that we will have the vaccine management system in place and functional by April. But there needs to be some additional annualized dollars to be able to maintain this infrastructure, including a team that can troubleshoot and support the various systems. We don't have those in place now. And so that's what that additional request of $1.5 million is, to continue the operations of these newly acquired, newly formed systems for surveillance, reporting, liaison with immunizers, as well as disease reporters and providers throughout the state. And the final issue is the AIDS Drug Assistance Program. Many of you are familiar with ADAP. ADAP is a HRSA based, so a Health Resources Service Administration federal program that provides HIV drugs to individuals with HIV infection. It is, as a federal program, requires a state match. We recognized in the last budget year, in the supplemental, you gave us sufficient money to allow us to continue into the end of this project period without starting a waiting list, which is much, much appreciated. And now this $9,853,740 is going to provide the necessary state match for continuation. We've never had the appropriate state match, which was recognized by the federal program individuals we talked to, and this will allow us to continue building the program without any concern about not meeting our match requirements. I want to again reassure you that we recognize we can't continue to keep adding adding additional clients and asking for additional dollars. But what we are doing is actively trying to improve and streamline the program, and where possible, move patients into a insurance continuation program off of ADAP or in lieu of ADAP, which will allow us to actually serve almost twice as many clients with the same amount of federal and state funding. And the other benefit that I see right now, and always have seen, is that this will also give individuals with HIV insurance that will cover their other health problems. As we unfortunately seen people with HIV living longer, they also develop other chronic health conditions, and this allows them to get that insurance for their other health issues. And so I really see a double benefit that allows us to serve more people, but also provides that additional support. And we are actively working right now with a program, but also potentially with a third-party contractor will help us to facilitate and improve the enrollment into the insurance program so that it isn't a cumbersome process for clients or for providers. On the next slide, I just wanted to briefly mention the federal grants that have supported much of our COVID response. Early on, most of, if not all of our response was largely based on CDC funding. We got directly from CDC through CARES 1 and 2. This paid for many staff in the districts, and much of it went out to the public health counties in the shape of grant and aid. So they directly got funding from us in grant and aid for their response. It also paid for 1,600 contact tracers, which we still have on board and responding to the ongoing pandemic. And at one point had 180 testing sites. That's been somewhat reduced now as we've redirected to vaccination, but much of that testing is still ongoing, either with public health staff or with contractors. Many millions of dollars of the federal funds were spent on laboratory capacity, largely external contractors who provided the testing externally, both to our SPOCs, but as well as a few enhancements to our public health laboratory. We have received some additional vaccine money, but I just want to point out that CARES 1 and CARES 2 virtually are already spent. Although it looks like we have $1 million, we don't. The CARES 1 and 2 have virtually been already expended in our initial year, or less than a year of our initial response. And now we're moving into CARES 3, as well as the immunization specific dollars from the CDC to allow us to continue our vaccination program, expanding that, getting additional staff as needed, as well as the large sites that we need to do large vaccination campaigns. The FEP dollars, the Public Health Emergency Preparedness grant, paid largely for the quarantine sites. That, although it was extended, we've functionally expended all those funds as well, and we're hoping we'll get additional dollars, but have not received assurances of that. And I think that pretty much summarizes the federal expenditures to date, but I'll be happy to provide additional information in more detail on a grant by grant basis if you're interested. I just want to mention a few things to bear in mind. We are seeing and have seen a significant decline in our high level of COVID cases over the last 2 weeks. In fact, a 40% drop in the number of our cases, but our deaths still remain very, very high. And I have to say that our age-based statistics are quite, I think, illuminating. If you look at actual deaths that have occurred within Georgia 85% of the deaths were in individuals over the age of 60. 66% of the deaths were in individuals over the age of 70. It was these statistics that led us to want to vaccinate as a priority those older individuals, because the vaccine was in fact developed with an endpoint of hoping to eliminate hospitalization and reduce the number of deaths. And I think that I'm still very confident that that was the correct choice, and hope that with the increased vaccinations that we're doing, that we'll see a decline in those cases, as well as the deaths in that older age group. And looking at the vaccination statistics themselves, this is a dashboard that has been up for quite some time. We just yesterday were able to post another dashboard, which also includes county-specific vaccination, including race and ethnicity data. Those data are not complete, in part because providers have not been filling out that information, and we are working closely with providers to ensure that they do fill that out as a critical part of our reporting process. What seemed to be a bit of a rocky start was in fact due in large measure to problems with the failure of our GRITS reporting system, rather than our inability to do this program, and which led me to recognize the need for an additional vaccine management system. The other thing I think that's important to point out is that there's a lot of discussion about logistics, and much of the logistics for vaccine transport actually is done by the federal government, not by us. The federal government ships us directly the vaccines. It comes to providers without having to pass through us. So we are not involved in, except in very rare cases, transport of vaccine from one place to another. It's shipped from either Pfizer or Moderna directly to a provider, or through McKesson, who's the contractor to CDC. And I think that's important to note that in a situation like this, where there's bad weather up north, we've heard there may be some delays in shipping, that we have no control over that. This is the federal logistics that are impeded by weather, but it will affect us at our state and local level to be able to get vaccine, into vaccine sites and into people's arms. I think the other thing that has been a great concern is the ability to schedule appointments. The biggest impediment to scheduling appointments right now is, quite frankly, availability of vaccine. We don't have sufficient vaccine to meet the demand that we have right now, but we have over 2,000 providers available, and we'll be able to roll that out very, very quickly to these additional providers, as well as to large vaccination sites that are being set up either with public health itself, through GMA, and through potentially FEMA at the end of March. But having said that, we need vaccine, and that is the rate limiting factor. I know that many of you have been concerned about the scheduling system. I have been concerned as well. And a modified and improved scheduling system based on a Microsoft Dynamics product will be rolled out next week. We had hoped it would be this week, but there were enough concerns that we had, particularly after the crash that the same product had in New Jersey. We did not want to roll it out until we were certain that it was ready to go. So we're looking no later than midweek next week, and we'll keep you appraised of that. And the last thing I wanted to mention before I open it up for questions is one of the things I literally have lost sleep over has been the ability for older individuals to be able to schedule it all. Many of them do not know how to use the internet. Many people don't know how to, many older adults, and actually younger adults too, and I put myself in that category, don't know quite how to navigate some of these systems or these hospital-based portals and other systems that are required to be able to get vaccinated. And so it doesn't matter if you have many providers, Publix and Ingalls and Walmart and Walgreens, if that requires you to have internet access and the ability to understand how to use these systems. And I am so pleased that we have been able to develop a partnership both with the Division of Aging and DHS, with the AAAs, the the agencies of aging in the all over the state. So it's a statewide program, and there are various programs for seniors. So this really reaches all seniors with a capacity to reach multiple demographics throughout the state. And they are working in coordination and conjunction with our health directors to reach out proactively to those elderly individuals who they know are in line to get vaccinated because of their age or because of their other services that they're receiving, or because they have been to the senior centers. It can provide not only the scheduling, but also transport to and from vaccination sites. And to be able to have that capacity as a partnership with both our sister agency as well as the AAAs, I think is just a very creative and just welcomed opportunity for us to be able to reach some of these highest risk individuals statewide. And I just want to let you know, because I do know many of you have had concerns, as have I, about especially those frail elderly being left behind. And I'm very pleased that this has happened really since we last spoke. And with that, why don't I just close and answer any questions you may have about the budget or other things that we're working on now.
Thank you, Dr. Toomey. We do have a question. Representative Hughley, I believe you.
Thank you, Mr. Chairman, and thank you, Dr. Toomey, for your presentation. We have gotten some emails from constituents concerned about the state's investment in public health, and the COVID crisis has exacerbated those concerns. My first question to you is, as you look at the lessons that you're learning from COVID, is there anything structural wise that we need to be aware of and pay attention to? And when I say structure, I'm talking about right now, your boards of health are all independent entities. Is there anything that we need to do in terms of this current arrangement that would make for better access and availability of programs to our citizens?
I think access is important, and also consistency. And I think that in whatever structure we have to ensure that we have access to everyone in every community, not just where a health department may be located, but throughout that whole district and county. And I know Representative Hughley, I know Columbus has been an area that we've been concerned about, because we want to ensure we have enough vaccine available to reach some of these highest risk individuals. And Dr. Townsend has been doing a great job in her work there. But I think also consistency. I think one of the things that I've been concerned about is one county may be doing something one way and another county may be doing something another way. And even though the health directors and I meet frequently and we agree, somehow it doesn't trickle down to the Board of Health, so that people are being turned away at some sites, being told that they have to be from that county only, when in fact we've made it clear that you can go to any county that's convenient for you. And being told, given other information that may not be consistent, and we may not have consistent use of technology. And I think all these things are of concern, because we want to ensure that every county is served in an equitable way and with the highest quality services. And I think that's what we're striving for. Whatever the structure may be, we have to ensure that always, that it's the highest quality. I think that's probably, I think that addresses your issues. I'd love to talk with you further if you have.
That's fine. I have another question for you. Um, when we talk about equity, we understand that minority communities have been very hard hit by COVID. And can you talk to me more about your plan for making sure that these communities receive the vaccine and what kind of plan you might have to address those citizens that we have that may be a little bit adverse to having the vaccines administered to them? What are we doing in that area?
No, I'm happy to answer that. And it's again something we've spent a great deal of time thinking about. When you see the new vaccine dashboard, you'll notice there is a discordance between the number of vaccines given to African American, but also Hispanic individuals. I mean, there's just far less of even taking into account that there's missing data. I think that hesitancy alone may not account for that. Some of that reflects hesitancy, and we know that based on surveys that we've done, both with our own team, but also with the Rollins School of Public Health. As recently as this morning, I've asked the Rollins School to repeat that survey to see if we can get updated data about the hesitancy within various communities, even as we are now working actively on some communications to reach these communities much more effectively than we've been able to do. We have overarching kind of broad-based communication strategies, but we feel strongly, I think you would agree, that we need to have really focused outreach, and in some areas, much smaller vaccination sites, and working with churches, working with community groups, setting up these vaccine locations in partnership with trusted members of the community, as well as ensuring that everybody understands the safety and efficacy of this vaccine. There's still a lot of concern, understandable concern about the vaccine and how it was rolled out. If we can try to address some of those, particularly with spokespeople from communities themselves. We have actually begun to stand up an equity council with members of communities across the state, and I'll be happy to share with you that final list as I'm getting now responses back from leaders who are willing to be part of this and anxious to be part of this and to help us message better, as well as serve as advocates in the community for vaccine allocation and administration, because I think it's going to take this kind of leadership and engagement with members of the community who are trusted, more than me standing up and saying, I think it's safe and effective, that will turn things around. And so I'm actually still receiving the feedback from individuals who will be working with us, and we can continue to expand that. But it's, to me, one of the most exciting things we've been able to do is with this equity council, really try to, in a creative and diverse way, work within the various communities around the state that have different needs. Not Columbus is obviously different than Gainesville. Gainesville is different still than Waycross. And I think as we learn from that, and with this leadership council, as well as try to develop these focal communication messaging, we're going to be able to address that. The bottom line, though, is we can't we still don't have sufficient vaccine supply. And I think that we will continue to be, hoping we get additional vaccine, but as we do get additional vaccine, ensuring that the vaccine is distributed equitably throughout the state, even as we're standing up some additional test sites like I've described, and particularly reaching those areas of greatest need.
I'm glad to hear that you have the Equity Council. I would love to see what that looks like and your members. And my final thing, I can't leave the mic without saying that Dr. Beverly Townsend is doing a great job for us in the Columbus area, and we really appreciate her leadership there. We sit on the Alabama-Georgia line, and Alabama has placed teachers at a higher priority in terms of getting the vaccine than we have here in Georgia. And that kind of creates a little bit of heartburn for us, because people on the other side of the river that are teachers are eligible for the vaccines and our teachers are not. Can you speak to our priorities for the vaccines, and are you still confident that we have the right set of priorities?
No, I'd be happy to. I mean, one of the things I'm aware of the Alabama change because I actually talk to the Alabama commissioner once or twice a week, and we were aware that he was doing that, although his message is that we don't have any vaccine either, and which is making it difficult to provide those additional vaccines. And that was one of the things that was, troubling us, is to be able, if you roll this out and add additional groups, it'll be even harder for those elderly who are most at risk of death and complications from the vaccine to be vaccinated, to have access to the vaccine. One of the things, all of us want teachers to be vaccinated when we have additional vaccine and we open up to additional criteria. One thing I will say, the CDC did publish guidelines on school opening, and Dr. Walensky herself said that vaccine is not a requirement to open schools. But what is a requirement is appropriate mitigation. And I've said that frequently to the superintendents when I've talked to them. Whenever teachers are vaccinated, they will not be in a bubble because the children themselves will not be vaccinated, and they will be also exposed and outside the school itself. But what we do know is that teachers don't have higher rates of COVID, but we can prevent transmission of the virus in schools with mitigation alone. And there's some very, very good studies that have recently been published by the CDC on that. So I from a scientific standpoint, I believe it's safe to move forward with opening schools and moving to the teacher and other school personnel a little later when we have more vaccine and are able to open up further. But we have to reinforce the need for mitigation. And I know nobody wants to wear masks every day like I'm doing now. There's a reluctance to spend the money on the kind of barriers that can prevent some of the transmission and be between desks or be between people sitting in close proximity. But some additional funding should be coming from the federal government to allow this to be passed down to the schools. And I really urge you in your leadership position, in your district, to encourage this kind of mitigation, because regardless if people are the teachers are vaccinated or not, there still can be spread in the schools without this kind of mitigation. And just to finish this discussion, we have actually distributed a vaccine hesitancy, I guess you would call it, survey to teachers throughout the state. And what we found is that somewhere between 20 and 30% of teachers only want it. I mean, it may be as high as 50%, particularly in some metro areas, but we're still seeing considerable vaccine hesitancy among teachers themselves. And so it isn't as if there's going to be a universal consensus among teachers that they want to be vaccinated. I think that's going to come with time, and also their assurances that the other mitigation measures are being taken in schools that won't be putting them at risk. So I think this is a lot, probably more information that you expected. We just got that survey back in the last couple of days, so it isn't published anywhere. It's, we're looking at those data, but those are kind of my thoughts. I mean, it's not that we don't want to do that, we do, but I also don't want to shortchange the older adults who are at highest risk for death and long-term complications if they manage to not be, if they manage to live through this this COVID episode.
Thank you, Dr. Toomey. We have another question from Representative Buckner.
Thank you, Commissioner Toomey, for the great work that everybody in public health's been doing, and for your kind words about Columbus. And I was interested in many of the questions that you just answered. But we've been hearing a great deal of testimony over the last week or so about nursing homes, skilled nursing homes, long-term care facilities, and I know that those are not directly under you as far as administratively, but one of the things that has come up repeatedly that's been a little disconcerting is that family members have talked about their loved ones who they have not seen since last March becoming sick with COVID, which the family members feel like, since they're in a nursing home type facility and their loved one got COVID and they had not been in there to see them as a visitor, that it had to be brought in by the healthcare workers. A lot of people are saying they don't want to change the visitation rules to take care of the healthcare workers, but there's been some different numbers about how well vaccinated the healthcare workers in these long-term skilled nursing home type facilities, whether they've participated at a very high level or not, and whether or not when patients in those facilities become sick with COVID, do you indeed do contact tracing? So there's two questions in that. Are the healthcare workers in those facilities being vaccinated at a decent level, I guess? And is contact tracing happening when the patients in those facilities come down with COVID? Thank you.
No, thank you. That's a really important question, Representative Buckner. Let me just say that one of the things that was, again, an epiphany, I was asked, what are things have you learned? This was one of the things that I learned, is that even when there's ample vaccine available, as there is in the healthcare setting, or in this case in the long-term care facilities where vaccine was provided obviously to everybody and made easily available, quite a few, and I would say in many cases, 30%, sometimes less, of the staff only participated in vaccination. And, one could argue, do we need to mandate that? Are there other things that we can do? By contrast, it was something close to 90% of the residents accepted the vaccination. And so you have a situation where you have vaccinated individuals, but in a situation where unvaccinated individuals who may be acquiring COVID in the community are indeed bringing it into the facility. I think that we have to continue, as we reach out about vaccine hesitancy, have to continue to address this with our healthcare workers throughout the state, but particularly in the long-term care facilities, because this is clearly a concerning problem to me and many others, that this has happened. Believe me, I am so aware of the loneliness that these elderly Georgians feel in the in these facilities, they want to see their family, and kind of what role will vaccination help to protect them, and others. Well, it's not going to help as much if we can't ensure that these staff are also vaccinated, and it's something that we have to continue to work on with the long-term care facilities. And I don't think Commissioner Barry's still listening, but if he is, I'm going to say, help work with us on this, because it's something we need to continue. It's not too late for the staff to be vaccinated. We have to keep reminding how important this is. And I know that as even with our own public health staff, in the initial go through, in many of our rural health departments, only about 20 or 30% of our own staff were vaccinated. So I recognize that that's, an issue, and we have to continue to reinforce this messaging. I guess I do want to say that the vaccine, as effective as the Pfizer and Moderna are, and it appears that the Johnson & Johnson will be nearly as effective, it doesn't fully protect you against getting COVID. And so it's nothing is 100%. And they were tested to ensure that it prevented death and hospitalization, really to protect in some ways not only the individuals vaccinated, but to keep hospitals from from overflowing and not having the capacity to treat COVID patients. But you can still develop COVID, and when we know of individuals who've been fully vaccinated 2 weeks out, more than 3 weeks out, and have developed COVID again. So I think that even with the complete coverage of most residents in these facilities, that's not sufficient to protect them completely from COVID. And we have some more education to do. And I really appreciate that you brought this up, because it's an important issue.
Some kind of solution that would be at least happy for some.
Thank you, Dr. Toomey. First of all, I want to say thank you to you and your staff. I've seen them in action, and I know that many of your folks for the last year have been working almost 24/7 to try to combat this COVID, and just want to say thank you to you and give them a shout out, and I hope you'll pass that word along to them. But let me ask you this. I think one of the real keys to the puzzle, to the problem that we have, is if we can receive more vaccine, then you're going to be able to get more shots in the arms, and I think that's going to solve a lot of our problems. Are you beginning to get better information about how much vaccine you are receiving or coming into the state, and when, so that you can plan better and our locals can plan better when they know that they're going to receive a shipment, so they can set up a vaccination day or something like that?
No, thank you. That it has gotten better in the sense that they project out now 3 weeks in advance, which wasn't happening before. In fact, we didn't know literally from day to day how much our allocation would be. It sometimes changed overnight, and you had people scheduled and then had to cancel a clinic. So that's that has gotten much better, and the fact that they have promised us that they will schedule out and keep our allocations consistent for at least 3 weeks, so that we can schedule appointments and not have to make changes. But of course, who can predict that you're going to have a weather event that stops any shipments of vaccine, as is happening potentially now? And so that there's always the challenge of what we are facing. I think that's, but I do want to comment that although a lot of additional vaccine is not available, about 30,000 additional doses or so, and potentially some more coming in for some FEMA-run vaccine sites, maybe in late March, early April. Our ability to predict and count on the vaccine allocation has gotten better, and that's made it easier to plan our vaccine campaigns, throughout the state, and for private providers as well. I don't think I answered Representative Butler's question about contact tracing. And I just want to say, yes, we are doing contact tracing very diligently, actually. Nursing homes is our long-term care facilities are one of the areas where we do our most intensive follow-up because of the potential risk for transmission to residents. So that is one of the high-risk areas where we follow up, as are the cases of variants, and we're seeing more and more variants and are likely have spread throughout the state. So thank you, Representative Parrish, and sorry, Representative Buckner, I forgot the other question.
Well, Dr. Toomey, thank you, and again to you and your team, thank you for the good job you're doing out there trying to keep us all safe. That concludes our questions from our group. Thank you very much.
Thank you all so much for your support and commitment to public health.
Great. Next on our agenda, we are going to take public comments. We have 3 people who have signed up to speak in person, and then we have, I believe it's 3 that want to speak virtually. So we're going to begin with this and be happy to hear from you. We'd like for you to keep in mind and be considerate of everybody's time. And if you have public comments that you'd like to give to us in writing, we'll certainly be happy to take those and make sure that everybody gets them. So first on the list that we have that has signed up to speak with us today, Amy Odom. If you will, when you come up, please identify yourself and the group that you're with, and we'll be glad to hear from you. Thank you.
It's on here. There you go. Thank you so much, Mr. Chairman. I know that I'll keep this brief because you and I have spoken about this, and I wanted to give the other committee members an opportunity to hear about this important service that's being provided currently for dual eligible patients throughout the state. I've provided you with some information, documentation on the actual issue itself. My name is Amy Odom. I am with Parker Poe Consulting, and we represent Trident Care. They are a wholly owned subsidiary of MobileX, which provides mobile x-ray services to individuals that are dually eligible for Medicaid and Medicare, both in a skilled nursing setting and in a home setting. What they do is they are asked to come in to a facility if a patient seems to have fallen ill, started a fever, perhaps fell out of a bed. And the purpose of the mobile x-ray machine, which is about $179 per interaction, it's about the size of a small refrigerator, and it comes into a home or to a skilled nursing facility, and you're able to capture imaging that's read by Georgia certified radiologists. And this is a service we currently provide and is a covered service under Medicaid now, so that those patients are not having to be transported by ambulance for non-emergent care to identify whether or not they have a pneumonia, or if an antibiotic is actually being effective towards treating pneumonia, or if they have a broken arm, et cetera. As you know, it's generally over $925 to transport a patient non-emergent by ambulance to a hospital, and then they sit around in the emergency room for a long period of time and essentially are admitted, and they pop back out several $1,000s later and several days later. And so we're here today because currently Medicare pays 80% of the claim, and typically the total amount is then crossed over for the additional 20% to be paid by the other provider. So in this situation, that would be Medicaid. So since 2017, when it became a covered service, Medicaid has not been paying that 20% where a private insurer would do that for a non-dual eligible patient, which is making it difficult for these providers to continue offering this service, which is more convenient for the patients, less anxiety producing, et cetera, and saves the state significant amount of money per year. So the total cost to the state would be essentially $250,000, and the savings would be significant. So we have met with you and with others and with the governor's office, et cetera, and are just requesting that the Florida language that's on the 3rd page could be inserted in the budget and annually accounted for at around $250,000 a year.
Okay, thank you. Any questions or comments from the committee? Thank you, ma'am.
Thank you.
Next, we're going to hear from Lauren Greer.
Thank you, Mr. Chairman, members of the subcommittee. I'm Lauren Greer, and this is my colleague Danica Thompson. We are with McGuire Woods Consulting. We represent the Nurse Family Partnership. I know that we've had a chance to talk to a few of you, and we're excited to talk a little bit more with those of you we haven't had a chance to meet with about this remarkable program. So it's an evidence-based community health program for first-time low-income mothers who are at risk and don't have appropriate access to health care. And the goal of the program is to improve pregnancy and birth outcomes, child health and development, and family economic self-sufficiency. So NFP is a national program operating in 40 states and serve about 60,000 families a year. Georgia only currently has one program, and that's in Houston County. They started in 2012 through a partnership with the Department of Public Health and the Houston County Health Department with a little bit of federal grant funding. And they serve about 100 to 120 families a year. So NFP Georgia is the smallest footprint for the program with our neighboring states. And so we're here today to ask for help so that we can double our impact with some of the highest risk populations and complement the state's ongoing efforts to combat maternal mortality, improve physical and mental health of mothers, and create stability and economic opportunities for mothers and children to thrive. So there are several home visiting programs through the Department of Public Health, but unlike all the other programs, Nurse Family Partnership is the only one who pairs the first-time mothers with a registered, specially trained nurse. Enrollment in the program is voluntary. There's no cost to the families. And during COVID, they've actually been able to transition to a telehealth model without patient care suffering, and they've actually been able to take on a few more cases than normal. So the program begins around 16 weeks pregnancy and goes through 2 years postpartum. It's a three-phase program. In the first phase, the nurse meets with the mother weekly and gets her prepared for what's to come. If she doesn't have a healthcare provider, they'll connect her with a provider so that the mom and the baby can get the critical care they need during the development stage. She can also provide support for healthy diet, stress management, smoking cessation, if there's any substance misuse problems or domestic violence issues, the nurse has the ability to do that. And because they're registered nurses, they have the training and the knowledge to be able to recognize the warning signs for, that lead to maternal mortality and complications and poor birth outcomes both before and after the birth, because they are doing the hands-on visiting. So once the child is born, they continue the meetings. They become weekly to bi-weekly, and they help provide first-time moms with the things that lots of first-time parents can use. Parent coaching, understanding the milestones that your child should be reaching, and breastfeeding support and those kinds of things. But also they can screen for depression. Postpartum depression is an issue, and they can encourage moms to continue to seek women well visits for preventative services. Then finally, in the third phase, they shift focus more to the mom and what her future goals are and how she can create a roadmap for success so that she can become economically self-sufficient. Like I said, a lot of these women are low-income, first-time mothers, single moms, and so whether her path forward is continuing her education or getting gainful employment, and mitigating the challenges that sometimes create those roadblocks like lack of childcare and those kinds of things. So that's the third phase. Like I said, NFP is a national program, and they understand how critical it is in Georgia for these services. And so they have prioritized Georgia as a state that they really want to expand in. And right now they have an incentive fund available that provides varying matching rates for new and expanding NFP programs. And so, we'd like to be able to take advantage of that. And so we've provided, I think, two possible options for expanding NFP in Georgia. We understand the state dollars are limited, so we wanted to give you a couple options to consider. The first is to expand the current program in Houston County. They recently were approved to also provide services in Peach County, and adding 4 new nurses would also allow them to expand into Bibb County. And so, to serve an additional 100 to 120 moms in the 3-county area. And so that first option would add 4 new nurses to the already 4-nurse team. The second option would be to start a new NFP program in Southwest Georgia. A couple years ago, the House Study Committee on Maternal Mortality, identified Southwest Georgia as an area of the state that really needs these services desperately, and that, pregnant women have difficulty accessing general health care and specialized health care during these times. And so NFP has the data and the experience to show that they can make a difference in these areas, and that the nurses have the knowledge and can provide the access to care for pregnancy and non-pregnancy related conditions that can be exacerbated by lack of healthcare availability in rural areas. And that also, can help remove some of the geographical and socioeconomic barriers to positive outcomes, and that can lead to maternal mortality. So in closing, thank you for all that you've done for mothers and children in the state, and we thank you for your consideration on expanding this great program.
Great. Thank you very much. Any questions or comments from the committee? Representative Hughley.
Thank you, Mr. Chairman, and thank you for your presentation. If you were to expand in Southwest Georgia, where would it go?
I think we'd work with the Department of Public Health to maybe identify who, their best opportunities for partnership were. We've had, inquiries certainly from the Albany area. We have relationship with the maternal mental health program at Mercer, and I know that they have some of the rural clinics in that area as well. So, we'd be open to the exact location, but certainly anywhere in the area could use it.
Thank you. Thank you for what you do.
Thank you. Next on our list, Lynn Durham.
Thank you, Mr. Chairman and members of the committee. I'm Lynn Durham. I'm the president and CEO of Georgia Core, the Georgia Center for Oncology Research and Education. And we are a nonprofit dedicated to improving cancer care in Georgia through partnerships and innovation. I am a 3-time cancer survivor myself, thyroid, breast, and chronic myeloid leukemia. And I can unquestionably tell you that I am alive today because of research and innovation that leads to clinical trials to find new treatments and medications to fight cancer. Those clinical trials are happening throughout Georgia today, from large hospital centers to small oncologist offices and through regional cancer coalitions. Georgia Core acts as a convener and a catalyst to bring together the healthcare providers, researchers, academic institutions, patients, and survivors to improve cancer care in Georgia. During the 2020 legislative session, Georgia Core's state allocation through DPH's Adolescent and Adult Health Promotion Program was reduced by $300,000, or 30% of our state allocation. We are asking you to restore these funds to the FY22 budget. Georgia Core leverages those state dollars to educate Georgians about cancer prevention and early detection, to provide screenings and grants to local organizations, and to attract and administer grants, such as our clinical genetics program with the Department of Public Health that serves 55 public health clinics, our current partnership with Augusta University and the CDC to improve colorectal cancer screenings in Southwest and Southeast Georgia, and our grant with Northside Hospital and St. Joseph Candler to administer a grant from the National Cancer Institute that brings clinical trials to Atlanta, Savannah, Gainesville, Columbus, Macon, Rome, and Valdosta. Funding provided by the state directly improves cancer care and enhances research and innovation and to save lives. I have written testimony I'd like to provide to you just with more details about the funding and how we would use that. But please know that the restored funds would provide the infrastructure that we need, the people, the equipment, the data analytics tools that allows us to partner in rural, urban, and suburban areas of our state. Your support would help us serve more Georgians and improve survivorship rates for our family, our friends, and our neighbors. Thank you for your time and consideration, and I'd be happy to answer any questions you have.
Thank you. We do have a question. Representative Buckner has a question for you.
Thank you, Mr. Chairman. I just want to be sure I understand this. The money that you did not receive went to the area cancer coalitions around the state to help shore them up?
I'm not sure exactly how that worked, but yes, they received their full allocation. We did not receive our full allocation.
Okay.
So I guess I would put it that way.
Okay.
Yes.
So, and follow up, so the fund, I mean, the way that you work with those area coalitions is that they do the work in the local areas, but like issues or problems that can't be handled in their community can be helped out by your group or by the centralized office, and you are also looking for ways to find grants and additional opportunities and treatment facilities and kind of coordinate what they don't have out in the rural parts of the state. If they can get patients to you, sometimes you can help them out.
We do work in partnership with them. A lot of what we do is attract those larger grants to Georgia Core, and then we administer those through the regional cancer centers. So they can, for screening, say for breast cancer screenings and breast cancer license tags, we take those funds that are given and we take those funds that are given and then we give those to the regional cancer centers, usually $50,000 a year, and then they provide the screenings in their areas. So what we try to do is pull together to get the grants, and then we bring those out to the different communities. So we do work hand in hand. Today I just met with Aaron Hernandez up in the northern part, west part of Georgia. We're reaching out to all of the cancer coalitions to make sure we are working together and that it is seamless in how Georgia Core works and the regional cancer coalitions work.
One last quick question, hopefully, yeah, short. Research that's done on cancer in the state of Georgia is coordinated by other groups and Georgia Core, is that correct?
We help with the clinical trials. We help find the patients and accrue them to the clinical trials. We do work with our with our research universities and with our research hospitals to work all together to find those patients and accrue them to the clinical trials, yes.
Thank you. Representative Stevens, your button, did you have a question? Okay. Thank you very much.
Thank you, sir.
Next, we have 3 people who had signed up to make public comment through the internet here. And first is Dave Lamb. See if we can get him on. You got him?
Okay, can you hear me and do you see my screen?
We can hear you.
Okay, and I trust by now you can see my presentation?
Yes.
Okay, I certainly appreciate it, Mr. Chairman and ladies and gentlemen. I appreciate this opportunity. I want to talk to you about the caregiver workforce and those that help keep the folks in the homes and communities. We have seen the aging population grow dramatically in Georgia. The 15-year period, 2015 to 2030, it will grow 68%. Our workforce needs to grow with that. You'll see in the chart here The blue represents the Georgia CNA registry. Those are certified caregivers that go through special training all across the state. They run right now 2020, a little less than 68,000. Looking at population growth projected by 2030, we'll need almost 87,000, close to another 20,000. We have 2.4 million Georgians either over the age of 65 or under the age of 65 that are disabled. Those elderly and disabled make up 23% of our population. And right now, those Georgians, there are 36 of those Georgians for every registry caregiver, and 50% of those folks are going to need some type of care during the rest of their lifetime. If you look at data from the Department of Labor, and I apologize, the current year, last year data is not available yet, but if you look at my CNA, millions of caregivers all over the country show that Georgia caregivers expect to see a pay rate of $12 to $13 an hour. They also have confirmed that caregivers, and our turnover is well over 50%, that 55% of our caregivers are looking for more pay in their next job. Medicaid funds, we have over 1,700 providers of home and community-based services for personal support services. In the last 21 years, there is a gap of $8.27 per hour between the current reimbursement rate and the cost of living. That reimbursement rate in 21 years has only increased by 11.3%, while the cost of living is up 57%. We surveyed more than 1,500 providers last fall. 50% of those providers or slightly over were Medicaid providers. The alarming thing is that almost 53% of the providers were operating at a loss. Certainly COVID-19 has contributed to that, but wage pressures and workforce issues have been working at that for a long time. In 2017, Representative Petrie chaired House Resolution 1257, a study committee on the workforce shortage and crisis in home and community-based settings. So we see that 3/4 of providers are struggling financially, either thin margins or operating at a loss. So what does this workforce need? Well, first of all, as providers, we've all been very supportive of the more than $19 million in COVID relief that the long-term care facilities received. They need it. They have had a tough time. Providers that go into the home and into the community have had a tough time too. And we actually care for more elderly and disabled Georgians than are in long-term care facilities. So what is our provider scorecard? Well, we've shown that those that receive the care in home and community-based settings are safer and safer from COVID. This has been a very good learning experience for that to show how safe that they are. We also know that Medicaid care is significantly lower cost in the community setting, that the savings can be, actually 4 to 1, that four individuals can receive the care in the community versus one in a long-term care facility. So what's our ask? We need some short-term pandemic relief. There are CARES Act funds that are currently available. We need consideration for some help there short-term, but we need long-term help. Those providers, the 50% providers that work in the Medicaid arena, we deal with personal support services, 2 different rate classes, and we are seeking a 10% rate increase in the 2022 budget. The state funds requirements would be about $5.5 million. Now, you should have a one-page summary of this ask that I had provided earlier, and I'm willing to answer any questions, but certainly I appreciate the opportunity for y'all to listen and to consider these requests. Thank you.
Thank you very much. Any questions or comments from the committee? Thank you, sir. Appreciate you being with us. Next, we have David Russell.
Hey, can you hear me?
We can.
Awesome.
Go ahead.
Thank you, Mr. Chairman. As you said, my name is David Russell. A lot of what I'm going to say echoes a lot of what Dave just said. I work for Family Care Incorporated. That's a home care company headquartered in Thompson, Georgia. And today I'm representing the Georgia Association of Community Care Providers. The Georgia Association of Community Care Providers represents about 400 home and community-based service providers in Georgia, and we serve our elderly and functionally impaired population. These providers are caring for COVID-19 patients in their homes in the community, as Dave was just discussing. While not often publicized, we're struggling with similar issues as the hospitals and nursing homes in Georgia. Our employees are entering homes and communities with no knowledge of if a patient has contracted COVID-19. This places our employees at a higher risk than some frontline workers in hospitals and other skilled facilities, as patients are tested upon entry into those facilities. The increased costs for PPP, hazard pay, testing, and overtime have affected all our providers. Our group understands that increases may not be possible in the current economic environment, but are asking that attention be given to our home and community-based service providers. We have several concerns we wish to bring forward as justification for much needed home and community-based service provider increase of at least 5%. First, additional regulations have been placed on providers and the waiver program, leading to higher costs. Recent examples include the federally mandated electronic visit verification program and mandatory fingerprint background checks for all employees. RATback was promised so we would not have to fingerprint these employees each and every year, but thus far this is not materialized. Adult day health is also in critical need. Many of these facilities have closed and will not reopen post-pandemic. Additionally, there's a great deal of concern over the $15 per hour minimum wage being pursued at the federal level. While we agree these frontline employees deserve to be paid a very fair wage, the reimbursement rate, which has not increased in 7 years, isn't mirroring that mandated increase in expenses. And of course, there are limitless increases in costs associated with COVID-19. A 5% home and community-based service provider rate increase would help stabilize our caregiver workforce beyond the COVID pandemic. This is a critical issue. As Dave just discussed, it was addressed by the House Study Committee on the Workforce Shortage and Crisis, which was HR 1257-2018. Home and community-based service provider employees ensure aging and functionally impaired Georgians receive a high quality of life in their communities. This includes the opportunity for competitive integrated employment in keeping with Georgia's designation as an employment first state. At home and community-based service all home and community-based service providers and their employees, thank you for your consideration of at least a 5% HCBS provider rate increase. Thanks very much. Appreciate the time.
Thank you, Mr. Russell. Any questions or comments from the committee? Thank you, sir. Next, we're going to hear from Ned Morgans.
There we are. Thank you, Mr. Chairman. My name is Ned Morgans. I'm with Skylark Senior Care, and I am representing the Georgia Adult Day Services Association and Leading Age Georgia. We are with the adult day providers. We're one of the most cost-effective providers in the long-term care continuum of care. And we're really facing a very dire situation going forward. Nationally, I would say the vast majority of adult day centers have closed, and that's certainly the case in Georgia. I think all of the adult day centers in Georgia closed last March. A handful of centers have reopened over the summer and the ensuing months. And those that have reopened are looking at a a much reduced client load, percentage of occupancy and utilization. And so in many cases, that's probably 10 or 20% of what they used to be able to make. According to a recent Leading Age Georgia survey, Georgia adult day centers are very concerned about the ability to reopen, and this is something that is also mirrored on a national scale. This is an issue that obviously affects Georgia centers, but it's also nationally. And I think that with these centers, we just have not had the level of support that we need to be able to reopen successfully and to be able to serve clients and our senior members and disabled adults who need this home and community-based service. It is by far and away the most cost-effective venue for providing this care. But in order for us to really remain viable, we're going to need some support, funding support. So for the 2022 fiscal year budget, we are asking that the committee consider, first of all, a rate increase of up to 15%. While that's a large increase, the centers are looking at a sustained period of time where they will not be able to be at their pre-pandemic utilization rates. It has also been a significant, a long time since we've last received a rate increase. A House study committee advocated for a 3-5% rate increases. The third rate increase was never implemented. So we really think from a long-term standpoint that this is going to need to be, we do need this. The last time we did had a rate increase that 5%, that was approximately $200,000 from the state, considering the FMAP, the federal match. So it's not that large of an expense that we have there. The other thing that we are looking for is help with startup funds to help the centers to move forward, which we estimate somewhere in the range of $20,000 to $100,000 per licensed center. And then the third thing that we could really use some help with is working with the governor's office to be able to access additional funding, whether that's through the CARES Act or other stimulus funds that are coming through from Washington in the coming months, weeks and months. With that, I thank you so much for your time. If you have any questions, I can answer any questions on this, and I hope that you will consider the plight of the adult day care centers in Georgia. Thank you.
Thank you, sir. Any questions or comments from the committee? I see none. Thank you very much. I want to thank all of our presenters today, those that were with us in person and those that presented to us virtually. We thank all of you for your input, and if anyone has written comments they want to get to us, please get those into us as soon as you can. We'll be glad to take those into consideration as well. And thank all the members for being with us today, both in person and virtually, and we'll adjourn the meeting at this time. Thank you all.